Hello, everyone. Thank you for joining us today for our webinar on PSA key learnings for family physicians. Today, we will share the latest physician services agreement updates and discuss some of the key learnings we found through helping physicians adjust to the changes and continuing to help them maximize their revenue potential. Let me start by introducing myself. I'm Maral Sanassian, the Director of Client Success at DoctorCare. DoctorCare is the largest provider of billing and practice support for over 2,500 physicians across Canada. On average, we have helped doctors recover $25,000 to $30,000 of revenue per year. We also support approximately 25% of all Faux in Ontario. Our solutions and services are designed to help doctors ensure that they are maximizing their revenue, improving patient care, and growing their practice. Just so you know, all attendees are in listen-only mode. We are recording this webinar, so it will be available to you after the event. If you have any questions during the webinar, please do submit your question in the Q&A feature. Your questions and your identity will be kept confidential and will only be seen by us. We will do a Q&A session to answer some of your questions at the end of the webinar. Here's the agenda of what we will cover today. We'll start with a summary of the most recent updates from the PSA agreement. We will then go into detail and address some of the key updates thus far, providing insight and recommendations on how to keep track and apply these new changes. Topics that we will discuss include explaining the difference between the Q888 versus A888 and how to bill during the holidays. We'll talk about the new W3 explanatory code, the new virtual care funding framework, and how to bill for virtual services. We'll also discuss the extension of the temporary COVID-19 codes and some updates and resources for those interested in transitioning to a Faux. Lastly, we'll look at the future and share what to expect in the upcoming months. Also, a quick note that we do have another webinar that we hosted back in April, where we provided a high-level overview of all of the PSA changes. We will share the link of that recording after the webinar as well. Here is a summary of the most recent updates that have been implemented thus far. At the start of the agreement in April 2022, there were changes involving the Faux managed entry, which included the increase of 40 new Faux spots available each month. The minimum size for the new Faux also increased to 6. There was a compensation increase in April, which involved a monthly lump sum payment for year 2 of 2.01%, which was compounded year 1 and year 2 increases. And then in July, there have been changes to the after-hours obligations, with new weekend access and weekend requirements, depending on the group size. In that same month, a new weekly patient access measure was implemented. And then our most recent update, effective today, December 1st, is the new virtual care funding framework with new virtual care codes. We will go through this in more detail later in the webinar. Let's get started with the weekend access fee code. We've been hearing a lot of confusion among our doctors about the new Q888 code and how it differentiates from the A888 code. The Q888 is a weekend access fee code that allows physicians to bill for services provided to their groups enrolled patients for unscheduled visits on Saturday, Sunday, or the holidays. The value of this code is $37.60. And is valid until March 31st, 2023. The billing requirements are as follows. The patient must be enrolled to the Faux group of the billing physician. The service provided is an unscheduled in-person visit. Virtual visits by phone or video cannot be claimed as the Q888. The billing physician must offer at least 3 scheduled visits for each 3-hour Saturday, Sunday, or holiday block. The Q888 must be billed with a valid diagnostic code. Please note that the Q888 is applicable for enrolled patients only. Services provided to unenrolled patients during this block would use the most appropriate fee code as per the schedule of benefits, for example, the 8007. Now, what is the AAA? The AAA code is an assessment rendered in an emergency department equivalent on a Saturday, Sunday, or holiday for the purpose of dealing with an emergency. To claim the AAA, the level of service required is at minimum a partial assessment. A partial assessment is defined by the limited service that constitutes a history of the presenting complaint, the necessary physical examination, advice to the patient, and appropriate record. The AAA only applies for unscheduled appointments, not scheduled appointments. A scheduled appointment is one that has been prearranged, regardless of when that appointment was prearranged. For example, if a patient contacts a physician's office at 9 a.m. and schedules a same-day appointment for 11 a.m., the appointment is considered one that was scheduled. The main difference between the AAA and the Q888 codes is the matter of scheduling. When billing the AAA, the physician is not allowed to have any patient scheduled. The office will have to operate as a walk-in clinic and accept patients with time-sensitive matters, which is considered an emergency department equivalent. However, Faux physicians are required to offer both scheduled and unscheduled appointments to the patients during the after-hours block as per the Faux agreement. The Q888 allows for physicians to schedule patients and bill the Q888 for seeing unscheduled enrolled patients, provided that 3 appointments were booked or 3 slots were reserved for scheduled enrolled patients. Therefore, physicians should not bill the AAA during required weekend and holiday after-hour clinics. When the minimum required weekend after-hour blocks have been met by the group, the AAA can then be billed. Here's a table illustrating what code to bill for enrolled or non-enrolled patients for scheduled and unscheduled visits. For scheduled enrolled patients under the required weekend after hours blocks, you can bill an A007 and Q012. For the unscheduled enrolled patients under the weekend after hours blocks, you can bill the Q888 and Q012. For weekends, once the after hours block have been met, you can then bill the A888 with the Q012 code. For unscheduled, non-enrolled patients under the weekend after hours blocks, you can bill the A007 code. For weekends, once the after hours blocks have been met, you can then bill the A888 code. For scheduled, non-enrolled patients under the weekend after hour block, you can bill the A007 code. Please note, you can bill the A007 code or the best applicable fee code as per the schedule of benefits. For easy reference, we have created a quick reference guide around the Q888 weekend access fee code that we will share at the end of this webinar. Now, let's go through a couple of examples. An unscheduled enrolled patient sees a physician on a Saturday. The physician's required weekend after hours blocks have not been met. What do you bill? Since the weekend after hours have not been met, we would bill the Q888 for the intermediate assessment with the Q012 after hours premium because the appointment is with a rostered patient. The physician will be paid $48.88. Let's go through another quick example. An unscheduled non-enrolled patient sees a physician for an intermediate assessment on a Sunday. The physician is not on call and has no pre-scheduled patients for the day. What do you bill? Since the physician has no pre-scheduled patients, and assuming that the billing and payment requirements are met, the physician can bill the A888 billing code. The physician will be paid $36.85. Now let's talk about the new W3 explanatory code. The Ministry of Health is adjusting the claims submission period for OHIP fee-for-service insured and related services from 6 months to 3 months from the date a service is rendered. If you have submitted the codes within 3 months, you can fix your claims anytime as there is no expiry date. We have noticed an increase of W3 errors coming in our physicians' reports recently. If you need any assistance with your errors, please don't hesitate to reach out to us and we can help. Some other updates. There will also be an updated process for reviewing stale-dated claims to allow claims submitted within 3 months of the date of service that are rejected to a claims error report to be corrected and resubmitted after the 3-month claim submission timeframe. Further information on the revised stale-dated process will be communicated at a future date to assist providers with this transition. And lastly, the submission period for remittance advice inquiries, which are also known as RAIs, will be changed from the current maximum of 4 months from the date of the RA to 7 months from the date of the RA. All changes come into effect April 1st, 2023. Let's move on to virtual care. Effective today, December 1st, a new virtual care funding framework has been implemented. This means that the temporary virtual K codes are now expired and will not be used to bill for any future virtual care services. So what does this mean? What codes can you bill for virtual care? As of today, physicians can only bill the codes qualified under comprehensive virtual care services or limited virtual care services. We've been receiving a lot of questions from our doctors on how to bill for virtual care with all of the new changes and where to even start. Let's start with defining some terms. Comprehensive virtual care services are services that can be billed if the patient has an existing or ongoing patient-physician relationship. This means that the patient is enrolled to the provider or the provider's group, or the patient has been seen in person over the past 24 months. The codes are listed in Section 1, Appendix J of the Schedule of Benefits. On the other hand, limited virtual care services are billed for patients who are not enrolled and have not been seen in person. These two codes are listed in Section 2, Appendix J in the Schedule of Benefits. Let's look at how ongoing patient relationships are defined in more detail. In order to establish an existing ongoing patient relationship, there are 4 main requirements to consider. Number 1, there has been at least one insured service with a direct physical encounter between the patient and that physician in the preceding 24 months. 2, the patient has signed the patient enrollment and consent form and is enrolled to the physician or another physician within the same primary care enrollment group. 3, a specialist or GP-focused practice physician has provided a consultation by video set out in Appendix J, Section 1 of the schedule, or has provided any such consultation in the preceding 24 months to that patient. Any consultation billed as an insured service under the K083 or as an uninsured service funded under the Ontario Virtual Care Program and rendered prior to December 1st is considered evidence of an ongoing or existing patient-physician relationship. Or number 4, a physician provides any of the following services or has provided any of the following services listed in the preceding 24 months. Other than for family physicians providing virtual services to enrolled patients, once an existing ongoing patient-physician relationship has been established, virtual services are payable for any necessary virtual follow-up care for the next 24 months. Depending on which services are medically necessary for a given patient based on their unique clinical circumstances, a patient-physician relationship may either continue or end after 24 months. For specialists, GP-focused practice, or family physicians who do not practice in an enrollment primary care practice, an existing or ongoing patient-physician relationship with a patient, and hence eligibility for payment of comprehensive virtual care services after 24 months of exclusively virtual visits with a patient, is maintained if at least one of the following is medically necessary and provided by the physician to the patient. For any physician, at least one in-person insured service. For any physician, any of the services listed in number 4 in the previous slide. For GP focused practice physicians, a GP focused practice video consultation. For specialists, any video consultation. Alternatively, limited virtual care services would be payable for any virtual follow-up care provided after 24 months, provided that the limited virtual care services are medically necessary for the patient. It is important to note one exception. For non-insured patients, physicians can still bill the K087, K088, and the K089 codes. The end dates for these codes have not yet been determined. These codes are available for in-person, telephone, and video visits for patients who do not have OHIP, another province's health coverage, federal coverage, or a third-party insurance coverage. Here are some virtual care payment parameters that are important to address. Existing requirements in the schedule, aside from a direct physical encounter with the patient, will apply to all virtual care services. Appropriateness. Virtual care services are not eligible for payment where it is not medically appropriate to provide the services without a direct physical encounter. Verified virtual visit solution. Video services are not eligible for payment when performed using a non-verified virtual visit solution. Geographic location. Virtual care services are only insured if the physician and the patient are physically located in Ontario at the time the virtual care service is provided. Moving on to availability. In-person services must be made available by the physician providing comprehensive virtual care services or by the physician's group within a clinically appropriate time frame if it becomes apparent during the virtual visit that an in-person visit is medically necessary, or if the patient expresses a preference for an in-person visit. Documentation. Virtual care services are not eligible for payment unless the delivery modality is documented on the patient's medical record. Change in modality has a greater part rule. So if during the course of a virtual care service, the modality changes, for example, a phone service transitions into a video service, physicians may claim the modality that represents the greater part, therefore more than 50% of their time spent. For time-based services, the combined time of both modalities will represent the total time of the service. Now, in terms of payment, the amount paid for each service differs between comprehensive virtual care services and limited virtual care services. For comprehensive virtual care services, the physician providing services to existing patient relationships rendered by telephone will be paid at 85% of the fee amount, while video will be paid at 100% of the fee amount. However, there are some exceptions. The K007, K005, K197, and K198 codes using telephone will actually be payable at 95% of the corresponding in-person fee. For limited virtual care services, the physicians providing services to those who they don't have a patient relationship with will be paid $15 for telephone and $20 for video. So how do we submit these virtual claims? The process is quite simple. For comprehensive virtual care services, the first step is to submit the virtual service using one of the fee codes listed in Appendix J, Section 1 in the Schedule of Benefits. And then after that, you must submit the code with a modality indicator that identifies the technology used to deliver the service. There are two modality indicator codes. The K300 identifies video technology used, and the K301 identifies telephone technology or audio technology used. To bill for limited virtual care services, all you need to do is submit one of the two fee codes, the A101 for video and the A102 for telephone. We created a virtual care services roadmap to help illustrate the process of billing for these new codes. As you can see at the beginning of the map, if you have an existing ongoing patient relationship, you would bill through comprehensive services. If you don't, you bill through the limited virtual care services. We also indicate the codes to bill and the amount payable for virtual services, depending on whether you are in a Faux or a FIG. Under the comprehensive virtual care services, Faux physicians will be paid 85% of the 15% of the fee submitted for telephone and 15% of the fee submitted for video. For out-of-basket codes, the Faux physician will be paid 85% of the fee submitted. For FIG physicians, they will be paid 85% of the fee submitted for telephone and 100% of the fee submitted for video. Again, please note that K007, K008, K197, and K198 will be payable at 95% of the fee submitted. Now that we know the exact process of how to bill for these codes, let's take a look at a couple of examples. First example, a physician meets a patient through video for a minor assessment who is not enrolled to them. In addition, they have not seen this patient in person in the past 24 months. What do you bill? Since the patient is not enrolled or has been seen in the past 24 months, we would need to bill the limited virtual care service with the code A101A for video. The physician will be paid $20 for any service provided through video with the limited virtual care service. Let's take a look at one more example. A physician meets an enrolled patient through telephone for a minor assessment. What do you bill? Because the patient is enrolled, we would bill one of the codes listed under the comprehensive virtual care service. For minor assessment, we would bill the A001 plus the modality code K301 to indicate that the visit was completed through telephone. Since the physician is a Faux physician providing an in-basket service over telephone to an enrolled patient, they will be paid 15% of the 85% of the fee submitted. The physician will be paid $3.03 for this service. With the virtual care changes taking place, it is important to make sure that your active patients are either on the roster or have been seen in the last 24 months. If you need any support with reconciling your roster, we can help. We can do a roster reconciliation to close the gap on rostering active patients that may have fallen off your roster. Please feel free to contact us after the webinar and we can help. Now, let's talk about the COVID-19 codes. The ministry has decided to extend the temporary physician funding initiatives to maintain patient access to healthcare and to ensure hospitals have flexibility in responding to changing needs throughout the fall and winter season. Here, we have a list of the temporary physician funding initiatives that will be extended to March 31st, 2023. Now, let's go through our last topic, Faux managed entry. As mentioned in our previous webinar, the ministry has increased the number of Faux spots available to 40 new Faux spots per month, and the recommended minimum size for a new Faux is 6. The amount of new spots will increase to 60 by April 2023, and they recommend all existing Faux to increase their group size to 6. Here are some of the common questions that we've been receiving in regards to the Faux formation. Can I stay in a comprehensive care model until I transition to a Faux? The answer is yes. You can continue staying in your CCM model until you find a Faux or a FIG to join. Do all the doctors in a Faux have to be on the same EMR from day one, or is there a grace period where they can share 2 EMRs? In this scenario, they must be on a shared EMR on the date of their Faux commencement. Is there a grace period when a new doctor joins an existing Faux regarding access and outside use, or will their negative access impact the group from day one? From the ministry's end, the impact is from day one. However, the Faux group's governance agreement will dictate whether there is a grace period for any negative payback mechanism. What happens to rosters larger than 2,400? No group will be able to form if they have more than an average of 2,400 patients per physician. Please note that this requirement is based on the average across the whole group and not at the individual level. If you would like to read up on other frequently asked questions around the PSA, we will share our FAQ blog after this webinar. In addition to the blog, we've also created several resources over the past few months to help doctors understand the Faux model. These include a guide to the income stabilization program, a guide to Faux group governance agreements, a transition to Faux checklist, Faux optimization strategies webinar, billing code basics. These links will all be shared at the end of the webinar. So now that we've gone through the current updates, let's take a look at what to expect for the upcoming months. In April 2023, the ministry recommends that all existing Faux increase their group size to 6. There will be some compensation increases, with the permanent year 1 and year 2 increases taking effect on April 1st, 2023, and the permanent year 3 taking effect April 1st, 2025. On March 31st, 2023, all family physicians in all primary care models are encouraged to have an online booking system available for their patients. If you need assistance with online booking, we highly recommend our partners at Ocean. The preventive care bonus updates will account for patients' comorbidities by April 1st, 2023. For the fee-for-service hard cap, the limits will be moved to the individual level April 1st, 2023, rather than being pooled into the group. The services that count towards the $57,069 hard cap will not change. And lastly, as we mentioned earlier in the W3 explanatory code section, by April 1st, 2023, claims for services rendered must be submitted within 3 months versus 6 months. There will be no time limit, though, to fix errors. We will keep monitoring for the latest updates and share them as we receive more information from the ministry. We know that changes can be overwhelming, and yet we are here to help and support you. If you would like timely updates to all the changes, we highly suggest you subscribe to our newsletter. Every month, we share all the latest changes and resources to billing-related subjects, including the Physician Services Agreement. To help you keep on track with all the numerous updates and equip you with the right resources to bill for services, we have compiled all the relevant resources mentioned in today's webinar in our blog. We have entered the link into the chat box. We will also share this link in a follow-up email to this webinar. Now, this ends the education section of the webinar. Before we move on to our Q&A section, I just wanted to share that we will be extending a special offer to all of our attendees today. Until the end of December, we are offering all attendees a complimentary transition analysis. We will do a free income analysis to show you the value of switching to a Faux model and help guide you through a successful transition. If you'd like to learn more, please do contact us, and we're ready to get started and help you out. Now, let's move on to some questions from the attendees. If you have a question that you would like to ask, please submit the question in the Q&A feature in the Zoom console. Your questions and your identity will only be seen by us, and I will read out your questions, but we'll keep your identities confidential. So we have a question on whether the Q888 is an in or out of basket code. The Q888 is an out of basket code, so physicians will receive the full amount when submitted. So we had mentioned that the K codes will no longer be used for billing virtual care. And the question is, what about other telephone and other virtual care fee codes like the G064, G271, G334? So for such codes, such as the G271, those codes were provided prior to March 2020, which was before the K codes were introduced as a result of the pandemic. Therefore, you can still continue to use those codes if they are appropriate for the service that you are providing. So there was a question about a combination of time-based care. So if I am billing an A001 and a K301 for my virtual care service, and the call is less than 10 minutes, would I need to bill based on the time spent, or would we treat it like it were a simple office visit? So when billing for any comprehensive virtual care services, you would bill the codes in Appendix J, Section 1, along with the modality code to indicate whether it was done through video or telephone. So you would need to follow the requirements as you normally would for that code. So in this case, you would treat it as a simple office visit. There's a question about the after hours premium and whether it can be billed with virtual care visit codes. So not all virtual care visit codes are eligible to be billed with a Q012 after hour premium. So if the following services are rendered virtually during after hours, then the Q012 can be added. And these codes are the A001, A007, A008, K005, K013, K030, and the K033. And then I'll take one more question. So there's questions about departing from a FIG to a Faux and whether a departure notice is required. So yes, departure notice is required, and the end date of your time in the FIG is going to be 1 day prior to your date in the Faux. So basically a day before your Faux commencement. So unfortunately, we have run out of time for questions. If we have not addressed your question, we will reach out to you directly to make sure that we get back to you with an answer. That is the end of our webinar today. On behalf of Dr. Carrot, thank you so much for joining us. If you have any questions or have any feedback on this webinar, please feel free to contact me anytime. My contact information is listed on the slide. I hope you all have a wonderful day.